Hello. Hi, everyone. Thanks for coming. I'm going to go ahead and get started. I'm sure we'll have some people filtering in, and there may be people on the stream as well. So I want to welcome everyone to the 33rd Annual Castele Lecture. This is our biggest named lecture of the year and our last lecture in our Grand Rounds series. So welcome and thank you for being here. This is a very Case Western-based lecture. So glad you made it. Hi. Is your brother coming? Not sure. We have a Castele in the audience, so welcome. Ted Castele is the one that donated to support this lecture and also donated to support the professorship that I hold at Case. He was a very generous contributor to Case Western Reserve School of Medicine and a very proud alum. He was also an alum of our residency program and really was a very generous radiologist within his community and affected many different institutions within the Cleveland area. Today's agenda, I'm going to give a little bit of a talk about Dr. Castele, and then we'll do our end of the year awards, our presentation of our Wei Shin Chin Award and our Hiro Fujita Award, and then our Alum of the Year Award. So Dr. Ted Castele made, again, a big impact in radiology within Cleveland, but also made a big impact in medicine through his role as a TV doc as well. He was a U.S. Navy veteran of World War II and was an Eagle Scout. He was also a 1951 graduate of Adelbert College, and he returned to Western Reserve to earn a medical degree in 1957 and went on to specialize in radiology. After his residency at university hospitals, he practiced at St. Vincent Charity Medical Center, St. John West Shore Hospital, and Lutheran Hospital. He was an active member in the Academy of Medicine in Cleveland and actually recruited me to be a radiologist at Lutheran Hospital and ended up getting a contract from Dr. Haga the same night and ended up signing with Dr. Haga and staying here at university hospitals, but I almost worked for Dr. Castele. It was always made clear that his top priority was his family. He met his wife, Jean, at a fraternity party at Case Western Reserve and was married for 63 years. Together, they had 7 children and 18 grandchildren, and I don't know how many more after that, Mary Kay, I don't know. Don't ask you to count? Okay. This is him on TV. He was on Channel 5, and he was really the first TV physician known in the U.S. He also held leadership roles on boards for local hospital foundations, the Case Western Reserve University School of Medicine, the American Cancer Society, Providence House, and the Boy Scouts of America. He spent much of his time assisting Case School of Medicine, and he even had his own office there for a time, very in the same area as the dean. And in 2013, received the Outstanding Fundraising Volunteer Award from the Association of Fundraising Professionals. This is a picture of his family and his legacy. And this was taken at the ceremony where I received the professorship chair here at Case with, right here in this lectureship. So I want to thank Mary Kay for coming and representing the Castele family. Thank you. Next guy, I'm going to move on to the Wei Shin Chin MD Award. Dr. Chin is an alum of our residency program and comes up every year to support us. His award is for achievements in radiology research by a medical student, and this is going to be presented by Dr. Naveed Faraji. Okay.
Well, I still can. Okay. Thanks. I'd like to join Dr. Pletcher in thanking Dr. Chin for his long history of supporting our department, both the educators of medical students and the medical students. All right, so as much as I would love to take credit for supporting Mia and her research, the fact is that I provide the same amount of support for medical students, and I've worked with a decent amount of medical students, and the output of those medical students can vary widely. But Mia is definitely at the highest end of that spectrum in the 2 full years that we've been working together. So a little bit about Mia. Let's see here, what do I got? Okay, so we met as she was an M1 as a medical student when I was teaching anatomy, and she expressed interest in radiology pretty early, and she's been steadfast in her interest in radiology. And the first project she took on was an article about the leaky pipeline and female medical students, and kind of losing medical students, particularly females who are not really making it to radiology residency. For those of you who don't know, there's a large gender gap in radiology trainees, and so we endeavored to study the literature about that gap. She led a team with 2 other medical students, one of which who was from Neomed, and that is a point I'm going to come back with later. But she led that team, was first author for that publication. In addition to that, Mia has done a lot of work in artificial intelligence, doing a lot of data collection, and presenting a couple oral presentations, one being last year at the Association of Academic Radiology Conference, which she did. I was very impressed watching, because usually you can tell I'm kind of nervous right now, but she's in this big lecture hall with a bunch of people, and just no stuttering, no hesitation, nothing. And very little guidance on my behalf about what she needs to do and talk about and things like that. One of her, this Neomed student who she didn't really know, she just worked with for this one project, was giving an oral presentation at CASE recently on a similar AI project that they worked on together. And just a testament to who Mia is as a person, she volunteered her time. I didn't ask her to come support this person who she only worked with on research, but she went out of her way to be present for this oral presentation for her colleague and friend. So I'm sure that she will continue that degree of camaraderie and professionalism as she goes on in her radiology career. So I guess, I'll stop there. But Mia, you're killing it. Keep up the good work, and come get this award.
There are stairs over here, by the way.
Actually, just fold that under his back. Nice. Let's see what more. Thank you.
All right. Dr. Chen, can you come up for a picture as well, please? Thank you. You can use the stairs over there. Yeah? No one's going to fall, and it's not going to be my fault. Great.
You want the screen off for the picture?
We'll take more later. It's okay. All right. Thank you. All right. And next is the Hiro Fujita PhD Award. I think this is going to be presented by Dr. Leo Kayat Bittencourt.
A long road.
Not a speech. Thank you, Dr. Plecha. Thank you all for being here. It's a great honor and pleasure to present the Hiroyuki Fujita PhD Award to Eduardo Correa, our research fellow for the year. And first of all, I'd like to thank Dr. Fujita and his family for the continued support to research in MRI in our department. We all know that our department stands as one of the leaders in the country, not only in the world, in MRI research, and we want to keep it so. And we are very honored to have this support for our incoming PhDs and trainees. So Eduardo was my first and is my first research fellow since I joined here. And I had to learn everything as I went, the same way as he did. I remember that I interviewed him on an afternoon, and he already had a job offer by the end of the interview because I knew that it was going to be a good fit. And it turns out that he was an MD PhD student in the same university that I used to teach back in Brazil. And I didn't know that he attended one of my lectures when I was teaching then. And it was very fortunate that we met back again. In the first meeting we had, even the day before he started working, I gave him some reading materials, and he was on top of everything in terms of prostate MRI. And I knew he was going to hit the floor running. And he just, within the first month that he joined the program, he already had his first publication accepted on MR fingerprinting. And he didn't stop there, of course. He already has 34 accepted and published papers on PubMed. 12 of those were done here during those last 2 years, not only with me, but with others in the MRI research group, where he also acts as a mentor on his own rights to interns and other fellows that come to join, and he serves in a number of committees there. He has had more than 20 abstracts accepted for conferences, and he manages more than 10 IRB protocols with excellence and on point with all of the research activities. And he was an instrumental part, a significant part in drafting and in helping to improve our own R01 submission, which was successfully funded as of last year. For many of those reasons that I'm so grateful for him, but not just for that, but for being a great listener, for letting me vent off every once in a while, and lending me his ear, and surrounding everyone with his kindness. In terms of awards, he also has like many accolades since then. He was on the cover of the American Urological Association News, their journal. He won the UH Research and Education Meeting Day Award for one of the best presentations. He got 2 certificates of merit at our SNA presentations, 2 papers invited or published at Radiographics. And last year we got the best of AJR, the American Journal of Röntgenology, for GU imaging for 2024. And if that wasn't all good news, we were so fortunate to have him matched to the radiology residency program here. So he's going to be joining in 2 years' time this amazing class that we have just matched. And he's bringing some of his colleagues to start doing research with us too. So thank you for that. And for all those reasons, Eduardo, we're so proud, so honored, so happy to have you win this award this year. Thank you very much. Oh, yeah. When he gets the Nobel, you'll see I was in the picture.
All right. Jeff, you probably want to stay up here. So next up, Dr. Jeffrey Sunshine is going to introduce our Distinguished Alumnus of the Year. We give this out every year for achievements in leadership in radiology and/or biomedical engineering, or biomedical imaging. These are just, this is our awardee today. I'm going to let Dr. Sunshine, yes, he's here. He's sitting right over there.
All right. There you go. Well, thank you all. This is always a huge pleasure. It is my pleasure to share, as the slide has, that Dr. Robert Gilkison, known to everyone as Chip, is our Alumnus of the Year. And it's my honor to try to explain why. So I'm going to share with you that Chip is an amazing human being, and in all the good senses of the word, a complex character. So I'm going to go down the list of some of his achievements, and you'll see how they move through so many different domains that reflect his extraordinary skills. First of all, he went to college like the rest of us, but in art history. And if you take Chip to a museum, it'll be an experience like none other you ever have. I recommend you do that. at no less of an institution than Princeton University. He then went to an unnamed place named Massachusetts General Hospital, where he was a fellow in the one mistake I know he's made, which was neurosurgery, because he left the neuro field to go to the chest field. But we have to forgive him some things. He did his medical school here at Case Western, where he was merely AOA. For those who don't know, that's the Honor Society of Medical Students. He then was an intern here at University Hospitals Cleveland, and his official resume says that he was a resident and fellow at Duke University, another unknown institution, where he was chief resident for 2 years. He's been everything you would expect him to be: a staff radiologist, a section chief for more than 2 decades, and a vice chair in our department to run the clinical side of research for more than, or just about 15 years. And he currently helps run the lung health program and direct that. And I'll be clear, of all the things we do in medical imaging, it is lung cancer screening that saves unequivocally, numerically, lives time and time again. And Chip's been central to that. He's published a few times, 225 peer-reviewed publications, 200 abstracts. He's been in 13 countries. I'll just stop there. He's world traveled and renowned. A few recognitions outside: U.S. News and World, Castle and Connolly, Cleveland Magazine, Top Doctors, Distinguished Physician, one of the earliest classes of those at university hospitals. He's had an Innovation Award, a Teacher of the Year Award only 3 times, and an Academic Achievement Award. He's done national service as a scientific committee on RSNA and ARS, executive committee on the Society of Thoracic Radiology, and editor of the Cardiac Imaging Panel of Radiographics. He's established here innumerable things that do what we do best, which is protect our patients: cardiac CT program, cardiac MR program, digital radiography, cardiac disease and lung cancer PI, and has personally helped us scan more than 250,000 patients for cardiac scoring and cardiac disease. All of that is singularly impressive, and the baseline of, but not the end of, why is he the Alumnus of the Year? First of all, he's still actively practicing. He could stop. He hasn't. That's part of his character. But I have to share a few other anecdotes along the way. First of all, he's officially a graduate of the Duke University Residency and Fellowship. What the form doesn't tell you is that he was a resident here in my class and had enough of me and had to leave halfway through. But as Chip will tell you, not before I had to cover the calls that he wasn't going to cover when he left. But I still think he should be Alumni of the Year. Chip is also a person's person. I long have teased him and said, "You're the chief political officer. You explain to me how to interact with other people, how to guide them where they need to go, even if they don't, and even if I don't know how to get them there." And Chip, I am singularly grateful for that education. I can tell you in my professional life, in my relation with Chip, that he knows more than most people the value of life and living. He has had to face many challenges, and he has done that with grace and dignity each and every time. And he is himself a miracle of a person, and extraordinary in every way I know. He inspires not only me, but innumerable others, from students to those of us who practice, to those of us who practice in the department, in other areas, and throughout the community. And finally, he could have retired numerous times over, but he is in love with what he does, and he chooses to do that every day. And for all those reasons, it is my pleasure to share Chip Robert Gilkison as our Alumnus of the Year.
He gets a bowl.
Thank you. Words or?
Words after picture.
Then I'll leave you the whole stage.
Excellent.
Congratulations.
It's all yours.
Thank you. Oh, 2 words. Yeah, you could have been so much worse. I know, you could have been. Thank you so much. As my colleague Amit Gupta says, Dr. Sunshine is like Shakespeare. He really is. He's always been like this. Jeff, thank you. And thank you, Donna. I always joke with Donna that Donna performs the annual sacrifice, which she goes to endless meetings and emails and political battles to allow us to do the fun stuff. And that's what we come, I keep coming every day because it's still too much fun. I guess that being an alumni a year, the retirement party is pretty close, but I'm not quite there. I'm having too much fun with you guys. I still do. And if I look at the list of fellow alumni of the years, I count among many friends, many models, actually many personal heroes. And I'm honored to get this award. There's so many thanks. I have to for 1 minute, so I feel like I can. So many thanks I want to talk about. All the achievements with CT, the amazing Les Santabello and Jen Sposato, and for MR, the amazing Mark Clampett and Marty Ayers and Ari Moss. In X-ray, the amazing Lisa Youngblood and Kathy Thaler. For my research and vice chair, what would I have done without for Veronica? Victoria Hoffman, thank you, and that amazing team. And for screening also, I used to call him Einstein with Les Santabello. We would never have done that 250,000 people with that incredible integration with both my amazing techs and my colleagues. So this is an amazing honor. I'm still here because just like many of my fellow alumni, we've devoted our professional life to this place, and we go here every day because we love it, and it's an honor, and thank you so much. It's been a great capstone to my career. Thank you, folks.
And as Chip said, he is among a lot of really amazing leaders in our not only PhD world, but the MD world for radiology. So we added him to the list this year. So congratulations, Chip. And now I'm going to introduce our speaker, Dr. Pari Pandharipande. She has earned her undergraduate and medical degree from Cornell University. She completed her diagnostic radiology residency at NYU. Her training continued with a cancer outcomes research fellowship, which I think has really shaped who she is in her career, and abdominal imaging clinical fellowship at MGH, and earned a master's degree in public health from the Harvard T.H. Chan School of Public Health. She previously spent 17 years at Mass General as a physician and researcher, studying topics ranging from imaging value to cancer screening, surveillance, and treatment selection. She also served as Associate Chair of Integrated Imaging and Imaging Sciences and an Executive Director of Clinical Enterprise Integration for Mass General Brigham Radiology, leading a transformative project for integration of imaging services across MGH, Brigham, and Women's Hospital, and their community affiliates. She also served as the director of the MGH Institute for Technology Assessment, a multidisciplinary health outcomes research institute, and led an NIH-funded research program centered in imaging and cancer outcomes. She then was recruited and served as chair of radiology at the OSU College of Medicine and chief of radiology services at Wexner Medical Center since 2021. Under her leadership at OSU, the department has substantially grown its imaging infrastructure, volumes, and service line, and has significantly expanded its training. I met her at the SCARD meeting, and we have actually lobbied Congress together. Last year, I was unable to go this year with Catherine Gullett, who's in the audience, to try and lobby for NIH support from the government. She also currently serves on the board of directors for the Radiological Society of North America, where she oversees the government relations portfolio, and on the advisory board of the ACR, Harvey L. Neiman Health Policy Institute. She also has served as chair of the American Cancer Society's Healthcare Outcomes Policy and Systems Grant Review Committee, and currently serves as a member of NIH's Organization and Delivery of Health Services Study Section. She is a past president of the Radiology Alliance for Health Services Research within the Association of Academic Radiology, and she has served on numerous local and national committees, including as a past longtime chair of the ACR's Incidental Findings Committee. She actually does not have an association with the medical school currently. She's moving from OSU and advancing on to Penn, where she will be the chair of radiology there starting June 1st. So please help me welcome her to the podium for her talk. I'm struggling to find your talk here. This is it? No? That's mine. This is it, right?
That's it.
That's it.
We added the slides together.
Got it. Okay. Thank you. I think we got it. Thank you. Done. You can go.
Thanks so much. That was quite a introduction. It is a genuine pleasure for me to be here. This is an incredible organization, incredible institution, and Dr. Plecha has certainly been an incredible friend in the field as a department chair and is a force in our field. And so it's a true honor to be here today. Here are my disclosures. So I'm going to start by saying that the talk generally is about how I got interested in health service research and how I use insights from research as a health system leader. But really, I think underlyingly, the talk is much more about curiosity and imagination, and about how, at least in my opinion, curiosity and imagination really drive what happens in healthcare, really drives what happens in humanity. But it's an incredibly important part of being a leader in radiology and in healthcare. You have to be able to ask questions, and you have to be able to imagine a world that is better than the world today. So I'm going to talk to you a little bit about that throughout my talk today. I'm going to start with a story from my internship. So when I started my internship, I started in the MICU. And the reason why I started in the MICU is because I did my internship in the same place, which I absolutely love despite this story. I did my internship in the same place at Cornell that I was a medical student. So I think probably they had people who were medical students in the organization start in some of the harder rotations, not because we were smarter than everybody else, but because we knew the system. And I thought it was incredibly hard. It was probably one of the hardest things that I did in my life. So I was trying to figure out how, a Swan-Ganz catheter worked. I was trying to figure out who I was supposed to bring breakfast for the next morning post-call. I was trying to figure out where I'm supposed to sit in that table, that rounds table. And I was just flat out lost. So what I did, which was the only thing I knew how to do, was ask lots of questions. So there was an attending who one of the attendings that I respected most, and that's part of what made the story kind of hard. He came up to me shortly after I started my internship, and he said, Pari, I feel like you ask a lot of questions. Why do you ask so many questions? So I said, well, I ask the questions because I don't know the answers. And he said, and he was trying to do the right thing. And so he said, when you ask a lot of questions, people think that you don't know the answers. And so I said, well, the thing is, I don't know the answers. And we blinked at each other a little bit, and we went on. And I thought, something's wrong here for me. Maybe not for everybody, but something's wrong here. I need to be in a place, I need to somehow start my career in a place And that place is Cornell. It's not about Cornell, but in some microenvironment where I can ask questions. And for me, that was research. So the next year, I had not really any significant experience in research, but between my internship and my residency, I'd spent a year doing research. I ended up loving my internship, but I made the commitment to do this. So how did I get into research? This is one of those things that happens in life that's just a great stroke of luck. So I actually, I'm dating myself. This was 1999, so there were not really cell phones, or at least I couldn't afford a cell phone at that time. And I cold called Dr. Neil Rofsky, who was an attending at NYU at the time. And their group was developing some of the first body MR sequences that we still use today. So volumetric interpolated breath hole examination, which I'll show you an image of shortly, short TRTE gradient echo sequence. They were developing those sequences that we're using today. I didn't know that. This was a great fortune of mine. But the other thing that I didn't know is what an incredible human being somebody could be to basically say, sure, come down to NYU and spend a year with us. And so that's what I did. And I did that with him and with a few other people who were there at the time. And the culture of curiosity that I had exposure to at that time in my life really just shaped the way that I think of academic medicine wholly. So we sat in a reading room together where we were interpreting the images. By we, I mean they. I was really just asking questions because there's nothing really else I could have done at that time. They entered the reports and the cases into a database that was used to do research that was used in real time to change those sequences and make them better. And it was an extraordinary experience. So Dr. Neil Rofsky, Dr. Vivian Lee, who was also in that group at the time, was one of my primary mentors, showed me how to write an abstract, showed me how to give a talk, went through that painful experience of teaching somebody like me who knew nothing, about how to do those things, about how to write a paper. And I'm forever indebted to that, and I think I pay that forward. I try my best to pay that forward as much as I possibly can. This is an image from the first paper that I published with this group. It was on extrahepatic complications of liver transplantations. You're seeing a mass in the portocaval space, which is a hepatocellular carcinoma recurrence. So then I went on to do my radiology residency at NYU. And I put this in here because I want to share that my experience in terms of really driving me forward in curiosity came in part from my interest in research. That was sort of the path and the journey that I took, but that is not the only one you can take. So Dr. Michael McCary was one of my abdominal imaging attendings at NYU. He died too soon. He died of cancer. He was somebody who talked to patients, and he talked to patients all the time. And his curiosity for people's lives and for how people live, I think, drove part of the way that he practiced. And he used to tell us as residents, talk to patients every chance you get. It is so important. You will learn more than you can imagine. So I thought I'd show a few images. These aren't from Bellevue. Bellevue is the public hospital at NYU, but they're of a type of case that we saw not infrequently at Bellevue. So these are images where you can see some cylindrical opaque objects, and those are balloons filled with drugs. And so this patient is a patient who was, if you look throughout the colon, you can see there are these cylindrical objects, and they're drugs that are ingested by this patient. At Bellevue, we had the unique experience of sitting and reading as residents close to where the patients were imaged. So we would see patients of all kinds getting imaged, and it really changed the way that it changed the way that I cared for patients, I think, enormously. Now, as an intern, obviously, I cared directly for patients, but as a radiologist, you have a choice to separate yourself from that or not. And I think that when you make sure that you're in some way in the space of the patients that you're taking care of, something changes in you. You see a patient like this potentially being escorted by police, and there's a sense of you understand a little bit, not entirely, but a little bit more about their suffering, and you experience a compassion that is hard to see or hard to experience if you're just looking at films. And my experience at Bellevue Hospital, without doubt, made me very passionate about the care of patients in public settings, public hospital settings. Now, at NYU, we trained in two great hospitals, Tisch and in Bellevue. And in Tisch is where the research program that we did our research took place. And so what were we trying to do? One of the things we were trying to do is to identify hepatocellular carcinomas within the liver using those state-of-the-art MR sequences. And we adjusted all kinds of parameters to do this as best as we possibly could. So when I went to my residency, I found that at Bellevue, at the public hospital, instead of screening for hepatocellular carcinoma with MRI, we did it with ultrasound. Now, it's important for me to note at this point that today, the American Association for the Study of Liver Diseases does recommend ultrasound for screening for HCC. So this is not a bad practice. But at the time, I was a resident trying to understand why we did things in different ways at the private and the public hospital, and I didn't understand, and I thought it was unfair. I said, everyone deserves the best test. Again, curiosity, I was asking my attendings, why is it this way? So they asked me back, well, Pari, what is better? How do you know what is better? Well, the sensitivity for MR is much higher for the detection of cancer in the liver than ultrasound. There's no question about that. But their point is it's not only about test performance. First of all, I was really only thinking about half the test performance. I was thinking only about sensitivity, which you can't do for a screening test. What about the specificity? What about the false positives? What about what happens after the test, the triage, the surgery risk, the transplant priority, the cost to patients, because we have to screen everybody. If you screen only a small portion of patients with a high-cost imaging test, you're missing the opportunity to care for a lot of people. These were hard questions, and they were not going to be answered with MR studies focused only on sensitivity and specificity, as important as those studies are. So I made a decision then at that point in my life to pursue health services research. So I went from NYU to do my fellowship, as Dr. Plecha mentioned, at Mass General, where I did clinical abdominal fellowship training and as well as a NIH-sponsored research fellowship in health services research, and specifically in cancer outcomes research. My mentor there was Dr. Gazelle. He founded the institute called the MGH Institute for Technology Assessment, which is focused in health outcomes research, and he also was my primary mentor, and I'm completely indebted to him for helping me to really launch my career in health services research. So I spent most of my career at Mass General Hospital. This is the Ether Dome, for those of you who might have been there. It's in the hospital. It's one of those places where if you visit the hospital, everybody wants to go see it. It was the dome where the first ether case for anesthesiology was performed. So one of the things that I loved about MGH was the expectation and sort of the experience of combined innovation and clinical excellence. And to me, this case exemplifies that. So this is a case from Mass General. And the patient here was weed whacking in their lawn. And a roof screw from the lawn flew up into their orbit. And so you can see this screw here. And it went from the right orbit back to somewhere in the vicinity of the posterior aspect of that sinus. The question is, though, where does it end? And with the artifact, it's very hard to tell where that screw ends. And what lives right here is a branch of the internal carotid artery. And so you kind of need to know how far back this screw goes. So there are two people working in the emergency radiology division on this day. One, it was an extremely astute clinical radiologist who's willing to push the envelope for better patient care. The other, also the same, but he also was somebody who was experienced in the physics of dual source imaging. And his research in part informs, I think, his knowledge about this space. And so together, they were able to use the dual source technology to do subtraction and to feel confident about the fact that while the screw traversed that posterior aspect of the sinus, it didn't go into the branch of the internal carotid artery. And so instead of taking this patient to the operating room, which would have been typical, they actually ended up removing the screw in the emergency room by pulling it out. And so, again, an extraordinary story, innovation, and commitment to patient care. So the MGH Institute for Technology Assessment, that is the institute that I went to do my fellowship and where I grew up as a faculty member from a research standpoint. The goal there is, the mission was to guide the development, evaluation, and utilization of medical technologies that improve the quality and cost effectiveness of medical care. What works now? Is there a better way? What could be better? Question after question after question. It was an extraordinary time to be there. I ended up going from being a fellow to junior faculty to an associate director to finally directing this research institute. A great fortune in my life. Now, the people here are people from our institute, a subset of people at our institute who were courageous enough to volunteer to be on an intramural softball league at MGH. But one of the things that I can't emphasize enough is that it's all about the people, and I'll talk about that at the end of the talk. But these people, each of them pushed the envelope on what we did in the institute during the time that I was there. And incredibly grateful for that. So what do we actually do in this institute? We build mathematical models of diseases. These are mathematical hypothetical models where we simulate the natural history of a disease across the population. Typically the US population, and typically very carefully to calibrate to different calendar years, to different processes and stages of a disease. Then we apply interventions, and we apply them hypothetically. So we say, what if we screened these patients with MRI every year, assuming we have this test performance of an MRI? What if we did that? Then what would the long-term health implications of that be in the population? What would the long-term costs of that be in the population? We had collaborators that range from smaller stakeholders to bigger stakeholders, as you can see here. The kind of impact that this had, Dr. Knudsen, whose paper, I took a snapshot of some results from a JAMA article that she wrote, but her model today is one of the models that informed, one of 3 models that informed the determination of when we all get colorectal cancer screening in the United States. This is an example of a graph from a paper that our research group published on pancreatic cancer screening in high-risk populations. This is a cost-effectiveness analysis. On the y-axis, we have the life expectancy gained per person, or the quality-adjusted life expectancy gained per person. On the x-axis, we have the incremental total cost of this population of patients with an STK11 mutation, so a high-risk mutation. And we're looking at MR screening. And what we find here is that there are MR screening strategies for these high-risk populations that would be considered cost-effective. So here we're looking at a screening strategy of annual screening starting at 40, which is about $70,000 per quality-adjusted life year, which most people would consider cost-effective. This is an example of a different type of study we did at the ITA. So this is probably one of the logistically most difficult studies that I did. So in 4 centers around the country, we did this study to understand the value of CT. We did it in emergency department and in primary care settings. Here I'm showing you the emergency department findings. And we did it in the settings of abdominal pain, chest pain, and shortness of breath, and headache. So 3 different indications. We wanted to understand before and after CT, what was the change in leading diagnosis? What was the change in management plan? What was the change in diagnostic confidence level? So I'm showing you here a snapshot of our findings from the ED. 1 in 2 patients had a change in their leading diagnosis after CT. More results from the ED. So here I'm showing you graphs which depict diagnostic confidence levels in our referring physicians. On the y-axis, we have the physician's diagnostic confidence levels. This is a physician who ordered the CT study. On the x-axis, we have patients with a change in leading diagnosis and patients with no change in leading diagnosis. This graph, or this study, this component of this study really informed the way that I think about referring physicians and how they use our tests. The referring physician who was working on this study with me, or one of them, Dr. Reisner, is an emergency department physician, not a radiologist, but a referring physician. And what he was very interested in this metric of diagnostic confidence. I was more interested in what happened in terms of the diagnosis, the management plan. And he said, Pari, you've got to think about the diagnostic confidence. That's what we're thinking about. And the important result here, from his perspective, was actually very simple. He said, well, if you look at the patients with a change in leading diagnosis before and after CT, you see that the diagnostic confidence level increases significantly. The patients with no change in leading diagnosis, it still increases, not as significant. So that kind of validates that the study is working properly. But he said that the most important thing was that everybody ended around 90%, all these indications. And the reason why that was so important to him was that if he was going to be comfortable making decisions about patients, you have to end in this range up here. You can't end with your diagnostic test confidence level about 70, even if it changed your diagnostic confidence level significantly. You have to end at that high level. You can't be sort of sure. You have to be pretty sure. And so when I think about AI, when I think about all of the new things that are coming in the pipeline for diagnosis, I think about my conversations with Andrew, with Dr. Reisner, about this graph, because he's telling me that that's where you need to be. You don't need to be this much better, you need to be all the way better. So the other thing that I wanted to talk about in terms of my experience, or the other couple things, pertain to more clinical stuff. One of them, Dr. Plesha mentioned, I was tasked later on in my time at Mass General to oversee clinical enterprise integration at Mass General Brigham. So this is something that's still ongoing today. And when I was tasked to be involved, it was the very beginning of it. And we were looking to transition to a subspecialized practice model focusing on quality and enterprise-wide scheduling, which focused on patient access. So these were the two main things we were focusing on in this enterprise integration work. We were really trying to combine the clinical aspect of the radiology practices, so we're at the beginning of that, with Mass General and Brigham as the academic centers, and then with the community practices. So the large community practices were North Shore and Newton Wellesley Hospital. Local services, universal experiences was the term that was used a lot at that time. So I'm going to talk a little bit about our practices transition to a subspecialized model as we envisioned it at the time that we were doing it in the early days. So we were going to support our practices transition to a subspecialized model, which I'll talk about in a second. We convened 9 subspecialty task forces to do that. And then the subspecialized practices, once they had formed, could then reasonably come into the fold with enterprise scheduling, because that means a patient could go to any site and would have the same access to the same quality care. And then we would extend that to the new MGB practices as they came on board or online. So transitioning to subspecialization in terms of these big systems is not easy. We did it by convening 9 subspecialty task forces, and we defined which exams required subspecialty expertise, which did not, and then we defined what were the qualifications for a physician that meant that they were a subspecialist. And a lot of what I learned in this process was really how to get people from different perspectives with different stakeholder needs and bring them together and gain consensus. So, for example, we took all of the radiology exams. We're focusing here principally on CT, and we divided them into those that were general, that didn't need a subspecialist, so CT for appendicitis. Those that were what we called subspecialty exams that could be interpreted by an abdominal radiologist. And among the subspecialty exams, there were those that were any abdominal radiologist could interpret, like a CT scan for staging cancer, like ovarian cancer, and those that required highly subspecialized expertise. And for that, we would say something like rectal cancer MRI. Then we needed to figure out what it meant to be an abdominal radiologist in our organization. How many months of fellowship? How does a mini fellowship count? board certification after how many years in practice. So once we figured out what exams needed to be read by a subspecialist and what didn't, and what it meant to be a subspecialist, then the subspecialized practices that were defined by that construct were eligible for enterprise scheduling. So this was my sort of big career foray into operational radiology at that scale, and I hadn't done that before. I learned a ton. I asked a lot of questions. But I think one of the biggest things that I learned was in the integration of multiple sites. Say this is your parent hospital. You can say this is the academic medical center, for example. You're going to look to try to integrate, let's say, with 2 other hospitals and maybe a hospital which is a smaller affiliate hospital of your academic center. So let's say they look kind of like this in principle. Before going into this project, I would have thought that success looked like this. So everybody gets a little closer to the academic center. They're not going to get quite there, all of them, but they're going to get closer to it. And in fact, what I learned was that success looks like this. It means that even the academic centers have to change. If you really want to have a universal experience, if you really want patients to get the best of your health system, you have to take everybody's input. And the skills that I learned from directing the research institute that I directed, from running the big multi-center study, those skills are the same skills that I ended up using to try to affect and move this project forward. I wanted to comment a bit on my experience as an abdominal imager. I know that this talk is focused on research, but the clinical aspect of my work is really important. And when I think about cultures of curiosity, abdominal imaging at Mass General was a big part of that. I had 3 leaders. Peter Mueller was the person who hired me. Deb Gervais was the person who was my abdominal imaging division chief most of the time that I was there. And then Avinash Kambatakone, who's the current division chief in abdominal imaging at Mass General, was somebody who was at some point in my fellow, although he always seemed to know a lot more than all of us, even when he was in training. All of them developed an incredible culture of curiosity, very familiar to me from what I had talked about during my experience at NYU. And one of the examples of this was during COVID. So this image is from an abdominal CT during COVID from a patient who had COVID, and this is COVID bowel with pneumatosis of the bowel. While the beginning of COVID was a very difficult time for everybody, and a lot of people were trying to understand how COVID was affecting their patients in different ways that we had never seen before. One of them was COVID bowel, but there were some leaders across radiology who had the foresight to kind of collect these cases and bring them together so that we could all learn about them sooner rather than later. And Avinash, Dr. Kambatakone, was one of them. So he did this. He did some path correlations. He involved our whole section, which I think is a tremendous demonstration of leadership in putting out one of the first papers about the gastrointestinal manifestations of COVID. Again, I think an example of how being inquisitive, how being curious and leading go hand in hand in critical situations. So I came to The Ohio State University in 2021. It has been an incredible experience, and it is an institution that I will absolutely love for the rest of my life, and it will have certainly have a big place in my heart. One of the things that I came into was COVID. So I left Mass General and came to Ohio State in the middle of COVID. And I came sort of right during Omicron. So Ohio State was one of the institutions that was subject to the contrast shortage. I don't know where you all stood with that, but it was certainly something that happened to Ohio State, and for me, it happened very, very shortly after I got there. So it was one of my first big challenges as a chair was to figure out how to navigate a contrast shortage at the organization level. And again, the way that I was able to do this was really to draw from some of those other skills that I had, some of them in health services research, some of them because of the logistics of the research that I had done, And some of them because the same kinds of questions that you ask in research, sometimes you also want to ask in clinical operations. We brought together subject matter experts from radiology, referring clinical services, supply chain, pharmacy, legal, ethics. We made a tiered system which informed how we utilized contrast, and we went forward from there. But those kinds of operational steps are very familiar and very similar to what we do in research and how we plan for complex situations in research. The people, I emphasize this again and again, the people are the most important thing. One of the things that I will say about the research projects that I've done that were complicated, as well as, something like the contrast shortage is, although I never would ever want something like that to happen again, when you have these intense experiences in your clinical or research environments, you solve them with people. The most important thing is people. And those complex situations then allow you to get to know people very quickly and in ways where you're sort of forced to trust each other very quickly. And that, I think, is an incredible experience and allows you to develop as a person, as a faculty member, and as a leader. So this is me with the dean of OSU, Dr. Bradford. We're writing the Pelotonia fundraising event together. We did, I think, a 50-mile ride. This picture I love on the with the skeletons doing the OHIO. I don't know if all of you know what that is. That was something that was given to me by my administrative assistant. And then this is us doing a hard hat tour in the new tower at Ohio State. But I got to know all these people well in the first 3 months, but really well after some challenging things happened, like the contrast shortage. So at Ohio State as a chair, I did the kinds of things that you do as a chair. We built teams. We expanded. We expanded our educational programs. We developed and advanced a new Center for Imaging Excellence, focused in translational research. We focused on faculty development and promotion, and we developed a peer learning program. So as Dr. Plecha mentioned, soon I'm going to be moving to become the chair at the University of Pennsylvania. Really sad to leave Ohio State, really excited for the opportunity at the University of Pennsylvania, where I'll hopefully put to work the experiences that I've had in the different realms that I've had in academic radiology. So in finishing this talk, I think the last things I wanted to talk about, I know this is at the resident graduation day, were a little bit about thinking about what inspires you. And I think that I've talked about research, I've talked about clinical operations, but my hope is that what I've really conveyed to you is what inspires me is people. I've showed you lots of pictures of different people along the way, and you may know some of them, you may not know some of them. The reason why I showed them is not necessarily because you know them or don't know them, but is because it's those people that have inspired me to do the things that I've done. There's this article that came out in the New York Times Magazine this month. I don't know if any of you saw it, which talked about the multi-decade-long studies of happiness, and it showed that, and this might not be groundbreaking for some of you, but it showed that happiness is informed by your interpersonal relationships and your relationships with people. Everything that I've talked about today has to do with people. It has to do with the people that I've showed you in my talk. It has to do with patients that have, whose in some cases whose faces I still remember, in some cases whose cases I still remember, and those are the things that motivate me. So finally, I wanted to end with one last thing about my internship. So one of the things that I get, and I thought I'd throw this out there because this is probably one of the questions that I get asked most. I think it's probably the first time I've ever addressed this head-on in a talk, but just since I've been asked it so much, I thought it might be helpful. One other thing happened in my internship, which was really interesting. So I was working together. The two of us were paired with another intern when I was during the Sloan Kettering part of our internship, and we had like a coffee break, and we went, which was rare, but we had like 2 seconds to go downstairs and get a coffee or a soda, and in that time, he told me that he wanted to be a chair, and in particular, a department chair of medicine someday, and I was just astonished because. Well, and then he asked me what I wanted to do, and I was completely like speechless because I was really thinking about the next day. That was pretty much it. Like my goal was to get through the next day and then maybe the next day after that. And here was this person who knew at the level of an intern that he wanted to be a department chair. And I thought that was maybe a little overconfident at the time, but I didn't really give it that much thought. I just knew that that's not where I was. And so then I went on in my career, and I began to appreciate that actually a little bit more. So years passed, and Dr. Sherry Cannon, who is, for those of you who may or may not know her, she's now the head of the faculty practice group at the University of Alabama, but she was for a long time the chair of radiology at Alabama. She came to give a talk at Mass General, and we got paired so that we met with each other. And I had just decided that I maybe wanted to think about being a department chair. And so I met with her, and I'll never forget, it makes me cringe to even just think about the meeting, because during the meeting, she was there trying to offer her mentorship and asking me a bit about, starting to ask me a bit about my thoughts about applying to be a department chair. And I said in probably the most sort of like the least assertive way possible. I said that maybe I was thinking of possibly, applying to become a department chair someday. And she, in the nicest way possible, said, if you want to do something like that, the first thing you've got to do is you've actually got to say to yourself and to other people, you've got to be able to articulate that that is what you want to do. And I think that was also obviously a very transformative moment for me in my career. But it takes something, and it didn't take something for my colleague who was an intern who knew that like off the bat. It definitely took something for me. I had to learn how to do that. But I put that out there because a lot of people ask about what the journey is to being a department chair. Everybody's journey is different. But if I had to look back and say that, I did everything the way that you should do it, I would say that's one thing that I didn't do as well as I could have. If you want to do something in your life, if you're motivated to do something like that, I think it's better to just go out and say that that's what you want to do. So with that, in summary, I shared a little bit about my career. I hope to have shared something about how insights from health services research can impact a leader's perspective. I hope to have shared about curiosity and how important curiosity is to healthcare and to the future of medicine. This is my final slide. It is an image from something that I'm going to miss enormously when I leave Ohio. So this extends, I think, to Cleveland, but there are these bike trails all through Ohio that go along train tracks. And I have spent like probably hundreds of hours on those bike trails during my time in Columbus, and have enjoyed that enormously. It's a beautiful state, and I will certainly miss my time here. Thank you for your attention. I'm happy to answer any questions.
Any questions? I just want to let you know that Scott Gazelle is one of our alumni.
As soon as I said it, I was like, I should have mentioned that. Yeah.
I remember him because I was a couple of years behind him, and we would look at images and say, doesn't that look like, a wolf or a bear or this or that? And we would challenge each other to figure out what these things look like. And when he went to MPH, he would mail me de-identified films of MRs and CTs without saying what it was, and we just send
That is awesome.
It was hysterical. He's such a great guy. Yeah. I'm glad he showed his picture. I think he had influence on a lot of people.
He absolutely did.
Yeah. Any other questions?
How would you, it was a great talk, how would you integrate health services research in a doable way to our residents?
Yeah, no, I feel like one of the things that I learned in becoming a department chair was how much the residents have to do. For the residents, I don't mean to think that I didn't think that the residents worked hard before, but just that there's so many requirements that are placed on, any discretionary time that you may have had. And so, it's a very hard thing. I think that there are a couple ways to do it. One is, through a more formal research program. So in the same way that some residents take a year to do in a research pathway, basic science or translational research, they can do health services research. And some residents, do that. I think the other way, though, is to integrate in some of the non-interpretive skills sections of the training some actual research, and not so much, the way that curriculum goes right now, at least from my perspective, is a lot of things like your 2x2 sensitivity specificity table, and you learn that, prevalence, positive predictive value, negative predictive value are prevalence dependent, whereas specificity and sensitivity are not. And that's the way you learn it. But that's really hard to learn. You can memorize that. I don't know that really just saying those words doesn't make sense. But when you put it into the context of a health services research project that has been, a clinical trial that has really borne that out, for example, I think that's another way that you can start to develop an interest, hopefully, in some folks in health services research.
Very shy.
Sure.
How do you see radiology through your experience, including health services research, continuing to play in the balance of value-based care?
So it's interesting. I think that to me, the big tension there is as follows. I think value-based care, when we think about value-based care as a construct moving forward as opposed to fee-for-service care, which it seems to consistently try to do, but we haven't quite got there yet. The big thing that will have to change is utilization. But changing utilization has been a challenge. And I think that it's hard for me to see value-based care moving forward without having a reinvigoration of utilization management. The challenge that I have with that, the challenge that I have with that is if you have the kinds of demands that people have on healthcare today, meaning you're in an office where instead of taking care of 10 patients, or you're in an ED, instead of taking care of 10 patients in a given time period, you're doubling that. Then imaging becomes part of the way that you actually care for those patients better, even though the utilization management might not be what you'd ideally want it to be. And that's where I think that's where the other side of the challenge is. I think that the one other thing that I'll say is that when you do analyses like the ones that I've talked about, where you're trying to determine what the cost effectiveness of imaging is, one of the things that's interesting in those analyses is often you'll find that the cost of the imaging, no matter, even if it's a lot, is not really the driver of the cost effectiveness analysis. Sometimes it is, but that's one of the reasons why it's important to map out the life horizon of of an imaging test. So I don't have a great answer. I think that, but I do think that if health systems move more towards value-based care, then I think that we have to go back to having a tighter control on the way that imaging is used. Yeah.
What happened to your friend? Did he become a chair?
I'm going to leave that out, but that's a great question. That's a great question. I will say that he is one of the, I still think that he was an incredible intern. It didn't surprise me. And he didn't say it in a way that was, he said it in a way that, as I said, at the time I thought might have been a little overconfident, but I think that was on me. I think it was just because I didn't understand at that time that that it was sort of my problem not to be able to articulate what I wanted to do. I think it was a strength of his, but he was an incredible doctor, and he's doing great things. Thank you very much. Sure.